Well, now we're going to talk, change to treatment of severe combined immunodeficiencies. What are the options that we have? And the first speaker is Theodore Moore, or Ted Moore, from UCLA. He's the chief of Pediatric Hematology-Oncology, and he's the director of the Pediatric Hematopoietic Stem Cell Transplantation Program. And he's also, I believe you were a fellow.
So just a special shout out to my mentor of 25 years ago, revealing some ages here, Randy Wada. And so, Randy, thank you, because I'm standing here today because of your investment in my life. And I would like to say that you're very, very fortunate to have Randy and his team here, because as we're talking about therapies and treatments, pretty much every kind of transplant, with just the exception of perhaps one, can be done here right at home, which means patients can stay here at home and have the support of their families. So that's actually quite wonderful. So let's go ahead and get started. Now, we could talk for hours about this, and we have limited time. So there's just a couple highlights that I want to get across to you today that I think are very important. So we'll move through relatively quickly. I have no conflicts of interest. And so the learning objectives in your handout are the following: that you understand just the management plans that are available and how we all work together. We'll explain why it's important for early intervention, and this is just a reinforcement in many ways of what's already been said. And then we'll talk about the long-term follow-up and management of these patients. So we've already talked about SCID and its importance, so we're not going to say anything else about that except at the very bottom. High early mortality from infections occur without early intervention. That's the take-home message for today. So what do you do for the treatment? You provide supportive care until you can do something more definitive, and right now there are two definitive things that can be done: transplant or gene therapy. So this is a very busy graph that just tells you transplant over the years. And the most important thing about this is really, in 1968 was the first transplant. And why is that important? Well, because it's over 45 years ago, and because it popped up and not in a planned way, transplant just popped up all over, and everybody sort of did their own thing. And this created a problem because it wasn't planned. What happened is everybody had their own way of doing things. And so over the last 45 years, there's many ways to transplant this group of patients as there are doctors transplanting them. And so because of this, people have actually worked together, and we're going to look at two papers very briefly and take just the take-home message from each one. But people started putting together some data from all of these 45 years and tried to make some sense of it, because depending on who you talk to, the conditioning regimen for transplant will be different. So just a couple things about transplant very briefly. When you do a transplant, regardless of the indication, there's a few things to keep in mind. When we're doing it for malignancies, we've got to give enough therapy to eradicate disease. Then the other two things that are important that apply to people with immunodeficiency is you've got to make space for the new marrow to go in, and you've also got to eliminate the ability to reject it. That's important. And again, for most people know this, but the transplant is not us going in during a surgery. It's just a simple infusion, and then we have to support them as they recover their immune systems. The sources, three sources: bone marrow, peripheral blood stem cells, and cord blood. And then defining a couple of terms. Allogeneic means it's coming from somebody else. If the somebody else is your exact twin. Identical twin, it's syngeneic. And then autologous, which means you get your own stuff back, and sometimes it's manipulated. So, and then a couple other basic things. So with bone marrow transplant, major barriers are immunologic. So in a normal person with a normal immune system, they can reject what you put in, and what you put in can reject the person, because you're transplanting the immune system. So these things have to be considered when doing a transplant. So if you're a parent and the person has an intact immune system, your cells can be rejected by the recipient, the child. And the same thing, if your child has no immune system, well, then those cells can go into the child and attack them. So when it does attack them, we call that graft versus host disease, and this is one of the major problems with bone marrow transplant, is the new immune system attacking the person. It's manifested in skin rash, gastrointestinal problems like diarrhea, and also liver problems. And so if a patient comes to transplant with problems, especially in the skin and GI tract and the liver, those can be nituses for graft versus host disease. So again, the healthier the patient coming in, the better. This is an example of graft versus host disease rash. And then conditioning regimens. We're not going to go through all the different types of SCID and the regimens we would use. For one, it's very debatable. But first of all, if you're a match-related donor, that's usually the best situation, and either no conditioning or just a little bit of immune suppression to get the graft in. Haploidentical transplants are usually conditioned or not conditioned, depending on the disease. And then patients that get an unrelated donor transplant typically need to get some kind of conditioning regimen in to get it to take. And then the main follow-up, we have to make sure the immune system reconstitutes okay. We have to manage the graft versus host disease, and then we follow up for the late effects of therapy. So enough about bone marrow transplant in general, and let's look at just a couple of take-home messages from a couple of papers. So I told you people started working together because everything was done haphazard in transplanting these patients. And so the Primary Immune Treatment Consortium, Immune Disease Treatment Consortium developed that basically was a number of institutions around the country, grant funded, to take a look at this. And there are major things being done is, one, retrospectively go way back and look what everybody's done and get all the data and put it together and analyze it. And so in this particular paper, which came out in the New England Journal last year, it's looking at those outcomes. And there's a lot in this paper. If you're interested, you can certainly look at it and read it. But there's a take-home message. First of all, they looked at over 240 patients from 25 centers with SCID and evaluated what the survival was at 5 years, how many reconstituted their immune system, in other words, didn't need IVIG or had good recovery, and then also whether the infection status at transplant made a difference. So ignore everything there except for one graph, and I'll show that to you. This is my pointer here. This one right here. And if you look at this, this is age at transplantation and infection status. There's a bunch of curves up here, and there's one down here. Down here are kids that are greater than 3.5 months of age and infected at the time of transplant, and their survival is around 50%. Everybody else is about 80 to 100%. Okay? So that's the take-home message. If you're infected at the time of transplant, past 3.5 months of age, it's a dismal outcome. Okay? If you're not infected, even if you're past 3.5 months of age, you can still do quite well. That's the take-home message of that paper in general. So, conclusions. Transplant from donors other than matched siblings were associated with excellent survival. So whether it's cord blood or haplos or unrelated donor, they all did great. Really, it was those things I mentioned. Were you infected at the time of transplant? Was the infection under control? So any type of graft source is going to be fine that we talked about. So moving on. Take-home lesson, before newborn screening, you probably were diagnosed when you acquired infection and survival was dismal. Okay? So just remember this. Dismal survival if you have an infection. Okay. So second paper, last paper, take-home message from this. Newborn screening for SCID in 11 programs in the United States. Again, published last year, sort of the taste of what we have coming in this country now, right? Because newborn screening is taking over, and how we're going to make a difference. So we looked at this. And what it showed was that 52 SCID cases in approximately 3 million infants. So again, as Maria said, the incidence more of about 1 in 50,000 or so. And looked at the different interventions and how the patients did. When you look at this, there are 44 patients that received transplant, 4 gene correction therapy, one of which went on to have a transplant, and 2 on ADA enzyme replacement therapy. How did they do? Well, 45 of the 52 was the overall survival, so approaching 90%. Again, approaching those curves we saw in the previous paper. The overall survival for patients who actually survived to treatment was 45 of 49, which is 92%. And the deaths, what were the deaths from? 3 of them were from perinatal complications. So things that didn't really have anything to do with the disease itself. And then post-transplant, there were 4. And the post-transplant deaths, infection in 2 cases that were already there, and then veno-occlusive disease, which has to do with the drug busulfan probably responsible for this, which in infants is very difficult to really target the dosing on, and that probably was the issue for those. So overall, that whole paper says, overall survival parallels the unscreened patients without infection prior to transplant. So if you can do newborn screening, you've all of a sudden moved everybody up to that top curve. So these are the key points. Age and primarily infectious status are the key determinants of survival in SCID undergoing transplant, with patients under 3.5 and patients of any age who do not have active infection having the best outcomes. So in other words, if you can, within 3.5 months, transplant them, which newborn screening can help you do, that's great. Well, what about the one that has a leaky SCID, or you don't know the diagnosis for sure, and you're waiting and waiting, and you pass that 3.5 month mark? Well, if you have them on supportive care and you're managing them, you're keeping them from having a serious active infection, you've just moved them into that category too. So you win on every point with newborn screening. Implementation of it is, as it says, going to be virtually all across the United States, and that will bring everybody up to a situation where they're survivable. And basically, the chemotherapy conditioning will impact the immune reconstitution, and certain patients, we have to watch what we use. Take-home message. So, what about these things? Looking to the future. That's my dog. That's his 3rd birthday. He always fits into all my talks. And he's looking to the next birthday already. So, looking to the future, how are we going to collaborate? And just very briefly, this is brought up, but the process, there's the initial evaluation of positive screens, and Dr. Mellish and Dr. Ching are going to do this via the flow charts that have been shown. The plan is to have families contacted within 24 hours of receiving the referral. They're also going to let Dr. Wada and his bone marrow transplant team be aware so they can start the process of being able to look for a match. If it turns out that person does not have SCID, well, then you're not left without essentially it's more important to get the process rolling in parallel, because if you don't and you do it sequentially, you lose time. Okay, so a presumptive diagnosis of SCID will be made, and then you'll start the supportive care measures until things can be confirmed, and those have already been talked about. Typically, Bactrim and fluconazole prophylaxis, using blood products as we described before, and changing from breastfeeding to age-appropriate formula until at least we get the CMV testing results back, and then IVIG administration. Confirmation of SCID will be done. We will be partnering with the teams primarily to be a sounding board. The folk here, if there are questions about the immunodeficiency and the diagnosis, we're here to help. Questions trying to sort out the best conditioning regimen for transplant, we'll all talk. But basically, we're a sounding board to help through the process. It takes time to get this authorized, can pre-screen for donors, and then make the best choice. And that is it in a nutshell. I tried to find a good LA rainbow. You guys have all the best rainbows. And that ugly downtown scene is the best one I can find, so I'll just end this with a photo a friend of mine took of downtown at night. He had to fight coyotes to get this, but that's the Griffith Observatory in downtown LA. So anyways, thank you very much.